I just started it, recording it to the cloud, so we should have it. All right. At any rate, this series of illustrations shows one way, at least, of splicing together the suture. I think it's probably the fastest and easiest way to do it. But if you haven't thought it through in your head, you might find it difficult. So I tried to make it clear with this set of illustrations. You'll see that you lay the two ends down side by side, and just with BSS allow the surface tension to hold the two sutures together. Then grasp both ends with your tying forceps here and wrap it away from you around the needle holder or around a pair of curved tires. Curved tires, at least in my experience, usually goes in your dominant hand, and the straight ones go in your non-dominant hand. So this is set up for a right-handed surgeon. So once you do a single wrap, then with the tip of the forceps, you have to go around and behind these two ends of the suture. So you bring it around, like shown here, and that causes the two sutures to cross each other. And then you feed the two cut ends into the mouth of the curved forceps, and it forms a figure of 8, like so. And then when you pull it through, you end up with this configuration here, actually. And then when you tighten it, this knot tightens up, and you can see that's a very secure knot. And I brought along for demonstration someplace a nice heavy rope, but I don't know where I put it at the moment. If we need it anyhow, I've got a nice heavy rope that'll show that more plainly. But once you cinch it down, you'll end up with a very, very small knot, and then you can cut it off here. And let's just see what we can do. Highlighter. You can cut it off here like so. And now you'll just have the two little ends sticking out, and you can separate the needle end from the end that's attached to the PKP, and then just start suturing as normal. All right, so any questions about that before we move on to the next one?
Beautiful diagram. I will say that yesterday I went to the wet lab and I specifically to practice that, and it was it was fun doing it. I will say that my 5 cents is that I figured that for the so-called new suture that you want to suture on, I kind of figured out the hard way after practicing it several times that once it becomes too short, then it's really hard to attach it to the loose end. So I think that my lesson learned from that is after, when it becomes shorter, it becomes tough. So I think you do want to have a bit of leeway on the suture you're adding to make it easier to combine the two loose ends.
How long would you estimate that makes it easy?
Well, I would say probably you want a good probably maybe 2 centimeters, 1 centimeter makes it like somewhere between 1 to 2 centimeters makes it easier to throw. And then always you can always shorten it afterwards if you found that it was too much. I found that just after because I took that piece, right? And then I used it to combine, then I cut it off. Then I used it again, cut it, just to repeat the practice. And then I realized that once it got around to maybe 5 millimeters, it started being difficult to be able to go behind my own loop, grab it, and still hold that other side to be able to tighten it. So yeah, that was the lesson learned from the wet lab, if that makes sense.
Yeah, probably 2 to 3 centimeters sounds like a good length to be able to do that. Okay, let's just go on here. So the other thing I wanted to go over was just so that we have it on paper of what the proper process is to tie sutures. At least if you're going to do it uh, with with a square knot rather than a slip knot. And so the next series of illustrations go over the principles behind it. And no matter where you are on the clock tower doing your suturing, if you maneuver your body and maneuver your hands such that they're in this position, it will go much smoother for you. And if it's not going smoothly, if it feels like it's awkward, then think about it and think if you're actually doing it the correct way, because it's a very fluid motion. It's first you wrap around, grab, pull towards you, then you wrap towards yourself, grasp, pull away from you. Then you wrap away from yourself, grasp, and pull towards you. And that should become very fluid. And what you want to do is judge the amount of suture that you want to grasp from the long end that gives you enough so that you can wrap, so that you don't have to go wrap, pull, re-grab, wrap, pull, re-grab. You want to only grasp it once in each suture maneuver to try and make things as efficient and as smooth looking as possible, because that's the name of the game, right? Is we all want to look smooth and we want to look cool when we're doing the sutures. But ultimately it's so that we are efficient. I learned that from a general surgeon that I worked with, that he was a liver surgeon. And he said that, you know, before you place any suture, think about where it's going and do it once and do it right the first time. You know, because they've got this cut end of liver that's bleeding all over the place. It's just oozing blood from all of these portal channels. And he's putting sutures in to try and stem the blood flow. So you know, you have to be very efficient in those cases. In our case, we need to be efficient because we want to minimize our open sky time, because God forbid you get a choroidal, you want to have that eye secured as quickly as possible. So principle number one is needle holder goes parallel to the wound. Sorry, before principle one, always after you pass your suture through the tissue, throw the needle over to the left-hand side. And if you do that, it will stay out of your way. That's if you're right. We're talking about anybody here not a right-hand surgeon? Anyone ambidextrous? Almost ambidextrous? No, me neither. But for right-handed, for all of us people that are probably in this 80% of the population, we throw the needle over to the left-hand side. And if it's over there, it will stay out of your way. If it's down here, or if it's up over on this side, it'll get in your way and it'll confuse you. So that's number one. Number two then is needle holder goes parallel to the wound. Tip number three is that the tip of the needle holder, and I like to suture with the needle holder, goes beyond the tract of the suture. So this isn't quite parallel here because, you know, I'm trying to draw in 3 dimensions, but the tip of the needle holder is over here. It's not over here. And that's a mistake that I see quite frequently when people are beginning suturing, is that they're trying to wrap the suture and they get frustrated because it keeps falling off the end. Well, if you look at the physics of it, you know, if you've got the tip of your needle holder here and you're dragging your suture over to this side, it's going to want to flop back over to the left-hand side all the time, right? So that's going to make it difficult for the throws to stay on the end. So by having the tip of your needle holder here while you're wrapping away from yourself, it facilitates the triple throw staying on your needle holder. And then once you've got those, each time you can sort of gently sort of pull over with your left hand over towards the right. And what that does is that it holds these throws and in fact pulls them up the shaft of your needle holder or curved tire, if you're using a curved tire, holds them onto the needle holder. And then when you go searching for your other end, it's not going to fall off on you. And what's even better is if you can place your needle holder, flick the end of the suture so that it's standing up. I learned that from Sprague Eustace, who was a fellow when I was a second year resident. You flick the suture, the nylon, the cut end of the suture so that it's standing up. And that makes it much easier to grasp it. And if you're really slick, what you would do is try and get the tip of the needle holder near your standing end of the suture before you even start to wrap. So I liken it to playing billiards. Does anyone play billiards? Has everyone played billiards before? I'm sure you have it at the pool hall, right?
Yes.
Badly.
Absolutely.
Well,
And under the influence.
What's that?
Badly and under the influence.
Oh, really? Well, billiards is sort of the common man's chess game. You know, is that you're always thinking one or two shots ahead, and there's a concept of playing shape, right? And what that means is that you're trying to set up your cue ball ready for the next shot, so that you're not just trying to hit the ball into the pocket, but you're trying to manipulate it such that the end position of your cue ball, which is the white one, right, ends up in a position to set you up for your next shot. And so that's what I look at surgery as like that, is that you should be thinking at least one move, if not two moves ahead of what you're doing. So by having your needle holder just adjacent to that end that's standing up, if you can manage the other things, which are, as we talked about, suture on the left, needle holder parallel, wrapping away from yourself, and then pulling to the right with your left hand. If you can manage all of that and at the same time be close to where the end of the suture is, then that's really playing shape, right? So then all you have to do is open the jaws of your forceps and grasp, and then left hand goes away from you, right hand goes towards you, and you've got your knot lying nice and flat onto the tissue. And you don't want to make it very tight. We talked about this before, but on your first bite, there's no tension on your tissue on the first bite, so there's no need to lock the suture. Oh, that's another suture hack that I can draw for you, is how to lock the suture. I'll do that for next time, perhaps. And so this illustrates the point, is that you've got tension going this way to hold the wraps onto the needle holder, and now you're grasping the cut end of the suture and lying it down with the triple throw. And this is the surgeon's knot that we were talking about when you do a double or a triple throw. So you're pulling in this direction here, pulling in this direction with your needle holder. And now the next point about suturing is that most of the motion is done with your non-dominant hand, your right hand, so it's not, you're not doing this, you're doing this, right? If you're doing this, it gets, I don't know, it gets confusing after a while. So your right hand is trying to set up next to the end of the suture, and you'll notice that when you do when you pull it down the first time, like over here, you don't have to go very far with your needle holder. In fact, all you should have to do is just move a little bit to the side and open the jaws as shown here. And now you're going to wrap towards yourself and grasp that end. And if you were to wrap the other way, like to make a slip knot, in order to get at the end here, you're going to have to do that maneuver. It's good that we talked about how to tie those two ends together, because that's the only time that you really should have to go around like that, you know, to grasp your suture, is if you're tying two ends together. But in this case, you shouldn't have to do that. But if you were to wrap, instead of going this way, if you were to wrap this way, you're going to have to go around it in order to grasp it, to get it to form a knot. So if you're doing that, then think about it once again, and you'll probably see that you've done it backwards. And that's so when I'm assisting you, you probably all recognize that I'll go, no, other way, and to try and help you make that correction. I see Tanya nodding her head. I don't slap wrists though, so don't worry.
Fond memories, don't worry.
What's that? It's a good memory?
Fond memories.
Fond memory, good. All right, and so then this is once again, so with the third wrap, you're going this way. So first wrap goes this way, second wrap goes this way, third wrap goes this way. And the needle holder has not had to move very far. All you've had to do is just move it a little bit, open the jaws, and then you're right there to cinch it down. You know, so the first triple throw is to lie the knot flat. You still have a little, you can still tighten it with your second one if you need to. So when you do the second throw, you're trying to just lock it, but not over tighten it. And then the third one is the one that you cinch it tight in order to lock the knot, and as well to make it small and compact so that it's easier to bury it. So I should actually make myself some notes, because I want to do one on locking, and excuse me for a second. One for locking the suture, and two for burying. Okay, so those are basic surgical principles, and I hope you found that useful. Okay, we'll discard the ink notations. All right, so let's see if we can move on to watching some videos now. If I can find them on this one. If not, I might have to switch over to my other computer. I think I'm going to have to go to the other computer. So let me see if I can just log on. Okay. All right. Are we getting? Oh, we're going to get all kinds of echo.
Just mute, exactly. que ahora está conectada desde los computadores. We can't hear you.
Can't hear me?
Yes, now.
Open microphone. Can you hear me now? Yeah, you
Yep.
can. Okay, so I might have to just use that for the time being. Okay, so we were talking about some complex DALK last time. Now, I guess I should press record just in, oh yeah. Are you recording it? Gisela, are you recording?
I can't. It says that I have to ask permission for the host. I already tried. I
Sorry.
might just retry.
Prof, you set it to record to the cloud, so it seems to.
It's still
Okay.
on.
Yeah, it
According.
looks like it's still on.
Okay, great.
Yeah.
Okay. So we'll go over some interesting cases with DALK. This was, I think I told you her story. She's an Aboriginal or First Nations woman with corneal scarring, probably from rosacea. You can see her. I don't have a picture of it here, but she's got probably had cystic acne as a teenager, and then rosacea, and ended up with corneal scarring. So we did a DALK on her, and she ended up with a double anterior chamber despite no perforation. So what do you think would cause that? Like, if you've got no perforation, why would they all of a sudden end up with
If you left viscoelastic.
Oh,
yeah, go ahead. Let's hear. Ayal, you were first at the draw.
I thought maybe if you will have a mismatch between the curvature of the cornea and the transplant, maybe it can be like, doesn't fit together well.
If there's a mismatch, yeah, I think that's possible, because often with the keratoconic patients, even though usually she's not keratoconic, but with the keratoconic patient, you've got a lot of surface area that you got to squash down. Sometimes you'll actually see folds in decimes. And our friend Alfonso Aviano, he wrote up a paper. I think he even maybe have devised his own little instrument that at the end of the procedure, you can stick it into the wound where the folds are, or opposite the folds, I can't remember. And that'll sort of smooth it out so that at least if there are any folds in the membrane, they're outside of the visual axis. So that's one cause. And Gisela, you said viscoelastic, if I'm, yeah. I think that's probably correct, that if you haven't been able to wash out the viscoelastic, and sometimes it's difficult, what I do is I take a Weck cell and I wet it until it's totally soft and soaked, and then wipe it across the membrane. And I'm not that scared about breaking decimes if you've got Dua's layer there. So if you've got a good type 1 bubble, it's quite safe. And in fact, they were talking at the seminar last week about doing phaco. If you've got Dua's layer there, I think it's really, I used to do that routinely until I realized how precarious it can sometimes be, particularly if you had a partial type 2 bubble or you've turned a type 1 into a type 2 so that all you've got is decimates. I had one case where I was doing a DALK for a zoster, and it was a really good bubble, but I didn't get, if my memory serves me correctly, I didn't get that nice expanding white ring that we talked about. So I probably had a type 2 bubble, and when I unroofed it, it looked pristine. And then I went ahead to do the cataract, and when I went in with my keratome, the decimates tore for literally 270 degrees and scrolled up like that. And the bad thing was, guess what I'd already done?
The rexus.
Oh, you already prepared the graft. You removed the endothelium from the graft.
Right.
Yeah.
Oh,
Oh no.
Yeah. So I was sort of in a bit of a, I painted myself into a corner. So what would you do in that instance? Aside from after you finish crying, that is.
And you had no other graft in the room, right?
Yeah. Are you KEI? Can you
No
just,
other graft. Last
So
case
you have to
just
close
sew
the
it
eye
on.
while waiting for a new graft.
You can just sew it on and then put a DMEC in later. And just leave them a bit swollen for a few days.
Yeah, you could do that.
Yeah.
How about closing the eye while waiting for a new graft?
That's what we mean.
Yeah, but you're saying so.
No, like a new PK.
I'm saying
Yeah.
so
I
like
would do a new PK.
I'm saying like so 4 sutures or 6 sutures, get like some sort of closure of the eye while you're waiting for your new PK coming up, and then just remove those sutures, put in your PK.
But he said there was no more tissue.
Yeah, but
and it's
not in the room. But he can order it, and maybe they can.
Well, we're at the Western, and it's quarter after 3.
That's what I thought he
And
was
the
saying.
nurses-
Like you don't have it. Like there is no extra tissue.
Were you able to unscroll the decimate that kind of scrolled up somehow?
Yeah. What about just
Was.
sewing the DALK and then putting an air
Bubble it,
bubble
putting
and
a
just
bubble in.
doing like a DMEC?
Yeah.
Right. That's what we did, and
That's incredible.
that's a good idea.
You just like go in with MST faucets and just do like your
Well, it was still open sky, and there's viscoelastic there, so I was able to sort of fold it back.
Wow.
And roll it back, and it's stuck. And then I put the new graft on and put an air bubble in, and tried to put enough pressure to express the viscoelastic out from the interface. And
I haven't seen this video, and because of that, I'm pretty sure that you didn't record it.
right.
Wait, I'd like to say, boss, I don't know if I can share my screen for a moment, just about the question about why you would have a double anterior chamber. If you could allow me to share my screen.
Yeah.
Something
sure.
that's just, so I think can I share?
Did it work?
I wanted to show you just one thing.
We made you a co-host, so you should be able to share.
Yeah, but I can't interrupt Dr. Rootman's sharing. I need
So
Dr. Rootman to stop
I can
sharing.
stop sharing.
Great.
Okay.
What I wanted to show you was this. You can see my screen, right? So like, again, sorry to be annoying, AJO with the Bucine's group, this guy there. So we actually looked into risk factors for a double AC. After DALK, 8% had a double AC. Overall of all their DALKs, 591 DALKs performed.
That's an amazing volume. Wow.
Yeah, the main risk factors were scarring, which I'm assuming just literally meant that they probably had a perf in those cases. But also, you can clearly see that, and in addition, intraoperative central, but the biggest risk factor is a type 2 bubble formation. That had the strongest odds ratio. So if you have a type 2 bubble, that is probably your biggest risk factor for having a double AC. Those were the findings of the study. In addition to scarring, which increases the risk, and obviously a perforation. So I just felt that this was relevant to the.
I wonder if that has to do with the smoothness of decimate membrane. Dua's layer, or pre-decimase layer, as they call it now, or some people call it.
Yeah,
I think
got
it's
picked up on that.
Yeah.
I wonder if it has to do with how far peripherally it goes. So maybe that influences the chances of double AC forming.
maybe. I think also pre-decimase layer is stickier. So you get, I would call it a
It's a strong-
Velcro-like effect between the posterior stroma and the pre-decimase layer.
It's like the
Without the-
difference between a DMEC and a PDEC. Like, you
Yeah.
have a little bit of tissue there. Did it work,
Yeah.
your case, Dr. Rudman?
She was detached, but we did an air bubble, and yes, she did finally reattach, and
Wow.
went back later
How
and
long
was
did
able
that-
to take out her cataract.
How long did it take for her to clear out, like just normal? Like a normal AC, like you just wait it out when you put a bubble in? It didn't take like months and months and months?
No, it attached within a week anyhow
Wow.
of doing the injection.
That's cool.
And
So-
did you, like, because I am not understanding 100%, like that decimase that had torn, did you suture it back where it should have been? You just injected it? Like open it up and inject the air?
Yeah, I just opened it up, put the new graft, the endothelial-less graft on top, sutured it, and as soon as I had, 4 or 6 sutures, I put some air in the AC to help hold it into position.
So did
That's
you
so
use
interesting.
tires? Like, did you just use your tires to unfurl it and then just?
I think so. It was quite a long time ago, so.
Because I was like,
I
you'd want tires because you don't want to tear the tissue because it's so fragile, but also like it's very difficult to grasp at the same time.
Yeah,
right?
I don't think you have to grasp it. I think you could just take a wax cell and wipe it back, or even just irrigate it back into position.
Mhm.
Try and do it
And
with as
what do you
little
think
touch as
about-
possible.
And what do you think about suturing the endothelium? Because I've seen some people, like if they have a tear in, they suture it, that they do their manual, and then they remove the suture, like to hold it in place.
I don't know, suturing decimase is,
Doesn't
it's
sound
like suturing wet toilet paper. Iris is like wet Kleenex, and decimase is like wet toilet paper. I tried it just experimentally to put a suture through to see if you could use that to drag it into the AC, but it just ripped through when it's a DMEC tissue anyhow.
And I wonder, like, if you would have placed the graft on top and started tapping, would it just not have unfolded the tissue, similar to the way?
Probably would have. Probably could have just done it, unfolded it like a DMEC.
Exactly. After you have the graft in place, start tapping. But again, easier said than done. I think my heart rate would be in the roof if that happened to me. And
Oh, well, you just got to deal with what you've been dealt. And if that's your hand, then you got to play your hand the way it is, and hopefully it'll work out. Sometimes the gods are forgiving, and you end up being lucky. And if not, so you say, well, we were able to put the new graft on. However, we had a problem with the membrane, but not to worry, we'll go back and put in a new membrane, which reminds me of another case. This guy, I'm trying to remember what his neurologic problem was, but he had a 5th and a 7th, I believe, and he had a very, very dense scar. And I wish I could remember what the cause of his 5th nerve was, but we actually did the case without a retrobulbar injection. And I did it as a DALK, and post-op, he didn't attach. He had a double AC. I think because his cornea was very flattened by the scar tissue, and the decimase just would not stick to it because it had been contracted with time. So you had the membrane, and then you had the cornea over top of it. So I went back also without anesthetic, just with IV sedation in the main OR, and I did a DMEC, and we did a big tarsorrhaphy because he had a 5th nerve. We did punctal occlusion as well, and he actually healed, but then he broke down and he ended up with a scar, And even though he had good visual potential, he insisted on having an evisceration. It was really very unusual psychosocial case as well, not just from the point of view of the cornea. But since then, I got to plug in. Sorry, I don't want to. This is why I bought a new computer, because my battery doesn't hold the charge very long on this one.
So if you have a type 2 bubble,
yeah.
how do you remove the viscoelastic? Because I wouldn't feel comfortable touching it with the wax, or just like BSS.
You mean to roll it back?
No, to just remove the viscoelastic after you've done your lamellar dissection.
Yeah, I'd probably.
Because I saw once a video of like a perfect dog with a type 2, and just with the BSS,
it washed out.
It
Yeah.
broke. It tore. So I don't know. It's just if you get a type 2, it's, I don't know, so scary.
Yeah, I think I would unroll it with the wax cell and just do my best. Assume that there's going to be viscoelastic, because I think that's one cause of getting a double anterior chamber is retained viscoelastic. Would
you consider maybe venting incisions if that's the case?
Well, with the DALK, do you need venting incisions? Because you can just go in through the keratoplasty wound and drain it.
Oh yeah, I'm sorry.
You may not have to, because the venting incisions, I've had some cases that they've caused irregular astigmatism if they're too close, or you get a little bit of hypertrophic scar tissue around where the venting and incision is. So I think retained viscoelastic might be a cause. The other time is, I think, inadvertent puncture of Descemet's or the pre-Descemet's with Descemet's membrane with your suture as you're going through. So this brings back memories of all the times, the places where I perforated. But I remember one case, a young guy with keratoconus had a really nice bubble. It might have been type 2. I don't recall, because I don't think even at that time I knew the difference between type 1 and type 2. But I was putting in the 4th suture, and the suture must have snagged Descemet's membrane, and it tore 270 degrees. So I ended up having to go back. I tried to reposition it and air bubble, but it ended up going about 2 weeks later to redo it as a PKP. I didn't try redoing it as a DMEC. The other time that we've been able to redo it as a DMEC is with a recurrence of granular dystrophy on the inner layers. And Adi wrote this up when she was a fellow. We had a few cases where we used the femto to make femto desmetorexis, because these were manual dissections, so they were much thicker. And then went in and removed the Descemet's posterior stroma complex and did a DMEC, which was really kind of cool. It was fun.
Prof, when you do perform a DALK, do you fill with air at the end?
Usually, I may not do a complete air fill. I like to leave some. If the case has been completely smooth, I don't think it's absolutely necessary. But if you've got a perforation, then you probably want to have some air. This is that young woman. We did the DALK, bubbled her, and then she went back home. And she came back, or we got a phone call 2 weeks later that she was in she had severe pain in the eye. And I don't know if you probably can't appreciate it. We can't appreciate it from the video, but she's got 360 degrees of angle closure. And this is the only case that I've had that this occurred. But I'm very gingerly trying to make a peripheral paracentesis. And you can see the mid-dilated pupil. So she started, I think, to develop more of nuclear sclerotic cataract. Now, I used to do these as triple procedures. I would do the cataract and lens at the same time. The advantage of that is you get rid of the big lens and you don't have to worry about angle closure and so forth. The disadvantage, look at that, you see how the angle is zipped up, and I'm using viscoelastic to free it from the angle. The disadvantage of doing it as a single procedure is that IOL calculations, and we lose the chance to correct the postoperative astigmatism with a toric lens at some point in time.
What do you think was the instigating cause here?
Here, I think that she had a congenitally narrow angle. Then we narrowed the angle further by our tight sutures, like, you know, the springs on a trampoline. Tends to flatten the cornea and narrow the angle. In fact, in the early days of keratoplasty, when they used to started out doing same size grafts, there was a high incidence of angle closure, and that's why it became very well accepted that when you do a PK, you have to do at least 1/4 to 1/2 millimeter oversize. But so I think the combination of that, then plus the enlarging cataract, further narrowing her angle, ended up with angle closure.
And I don't remember who it was. Was it Tycoon or Chu who said that they do a PI sometimes in these cases?
In DALK? Yeah, in routine DALKs I don't, but you know, if I'm going to leave a sizable air bubble, then I will do a PI. And I think that that's a good safety measure. I don't like to do it because often you end up with bleeding, or you end up with pseudopolychoria if your PI is very large. But so here we've made a phaco wound, and you can see the view's not terribly good. I think it looks like I put in some vision blue. Yeah, there it is. There's vision blue in there. I think that's what the pause was here, is waiting for the vision blue. There we go. And if you've already got viscoelastic in there, it's quite easy to go with your cannula and inject a little bit vision blue onto the capsule, and then use the cannula. I learned that from one of our former residents, David Yan. You'd use the cannula to paint and spread the vision blue across the capsular surface, and you'll get a fairly good staining. It looks like here I may have tried to open the capsule and then realized I better put in some vision blue so I can see what I'm doing. But so some more viscoelastic to push the capsule back. And we'll just increase the playback speed a little bit. How's the video today? Is it jumpy or?
Pretty good.
Pretty good. Yeah, that's good. And this is starting to.
It's super high mag for me.
Yeah, it's also, I did it under pretty high mag. I'm trying to catch an edge here. It's because looks like it's at risk of becoming a Argentinian flag sign. And we've got the red reflex intensifier on. If you get 3 lights like this, it means the intensifier's on. And luckily,
which viscoelastic did you use here?
I generally just use, you know, either Viscoat or Helon. I'm a little bit afraid's the wrong word. I don't trust Helon GV or Helon 5. It's very, very difficult to get out of the eye. The only time I've used it, I ended up having to go back to the OR 2 weeks later or a week later because I couldn't get the pressure under control, even though I thought I'd removed it. I find it really hard to get it out. So generally, if your paracentesis isn't very large and you don't excessively gape your wound, you should be able to maintain the chamber. And here we've got a reasonably round capsulorhexis. I don't know what I'm trying to do there. I guess just testing the edge or something. There we go. So we got the other edge. So we've got a fairly round rhexis, which is, of course, more elastic and stronger than having a tear that could possibly run out to the periphery. And some hydrodissection. And I was trying to remove that little extra bit of capsule, it looks like. And looks like this lens didn't require that much phaco, probably because it had been softened up by having, you know, maybe that's what caused her ankle closure, is she started to get some swelling of the lens. Perhaps I don't think there was any puncture of the lens at the time of the original DALK.
That's what I was wondering when I saw you at the beginning, before beginning your rhexis, like carefully examining with high mag. I was wondering if you were worried of a puncture during the DALK itself, and that's why you were, you know, slowly approaching the rhexis itself.
Yeah.
But would you go inside if your DALK was uneventful? Maybe for the
no, not really.
paracentesis?
Yeah, maybe there was a small puncture, but if it was a large puncture, don't forget, it's more than 2 weeks after the original surgery, maybe longer. Look how well the wound is healed. It's very unlikely that the lens would have remained that clear. You know, if you had a large puncture, it usually goes white on you, which brings me to another complications story. We had a woman of color who I did a DALK on. She had a history of keratoconus. And I saw her, I don't know, 6 or 8 weeks before the planned cataract surgery. We'd taken out all of the sutures and we booked her for cataract surgery. And she shows up on the day of surgery and she says, you know, my eye has been red. So how long's that been going on for? She said, oh, a couple of weeks. And I look and I go, oh, she had a totally white cataract. And the eye was obviously inflamed. So it's something that happened yesterday. So what would you do in that instance?
What was she a candidate for that day?
Well, she was booked she was more than a year after her DALK. Her original DALK went nice and smoothly, and she was developing a cataract, and we were booking her with a toric lens, etc., to get rid of her cataract. Sorry, can't
Sorry.
hear.
So what's happening right now is that because of her cataract, she has a inflammation secondary to the cataract becoming. Yeah. So do the cataract surgery.
Yeah, you got to go ahead with plan A, which was to take out the cataract anyhow.
So did you have a phacolytic situation, or was it an ankle closure situation?
It sounds like it's a lens-induced uveitis, what you're describing.
Sounds like a phacolytic uveitis, yeah.
Yeah. I think that's what she had.
Mm.
But tragically, she developed a retinal detachment afterwards. And I don't know what the relationship is between uveitis. Like, I took out her cataract, it was smooth and everything. So I was always wondering, which came first. I mean,
Were those definitely cells, or were those maybe RP, pigmentary cells from the detachments that you saw in the AC? I'm
She
wondering.
wouldn't be inflamed
No.
though if they were RPE cells.
Yeah, no.
Yeah, no, they were
She had a red
definitely.
eye.
She had a red eye. Yeah.
Yeah, so or it could be she had a uveitis that wasn't treated, and then therefore she got the cataract. That's why I was
Right.
asking if you think the inflammation was secondary to the cataract or not. Because if you think the inflammation is secondary to something else, then you would have to treat that first and wait for it to quiet down and then do the cataract.
Yeah.
As opposed
Well,
to
I think
you
she needed the lens out. I don't think we could have left it. I think it was probably phacolytic, but
How do we know if it wasn't like RD before the surgery?
well, we could have done a B scan, but she was sitting there waiting for the cataract surgery. So, and the retina guy would want the lens out anyhow. So I decided to go ahead with it. But yeah, I guess we could have sent her upstairs for a B scan to see if the retina was attached. My question was whether there's any relationship between the inflamed eye, maybe with choroidal inflammation, and can that lead to an RD? I don't know.
It was a rhegmatogenous retinal detachment with like an identified tear. It wasn't like some sort of odd
Arthritis.
yeah, it wasn't like a serous or a retinal detachment or anything like that. Sorry that I'm going into the unknown of retina, but it was if there was like a clear tear, then it shouldn't be related somehow.
But a
Yeah.
clear tear can cause Schwartz syndrome.
Yeah, but he's saying that she had a
Say
red
that
eye.
again. She had a red
Schwartz
eye.
syndrome can get like IOP can go up.
You think she had an
Yeah.
IOP spike, and what the cells you saw were maybe RPE cells, and the red eye was from high
No,
IOP?
they weren't RPE. They were definitely, they were like mutton fat KP. She had like her back of her cornea was covered with big clumps of inflammatory cells. Yeah, but these are all unknowns. So you said with uveitis you can get a serous detachment, right? I think her pressure was low, if I remember correctly. It wasn't a high pressure situation. The eye was soft. But anyhow, that was, interesting cases that we've encountered over the years and how to deal with them. And so she's, let's just go a little bit ahead on this because we're, so the lens went in, we put in some myostat, and now we're just gonna do a stitch. And actually the patient's done quite well. She has ended up, I don't remember what her vision is, but I do remember that her friend is a First Nation artist, and he made this beautiful painting. It's about 11 by 14. I got it downstairs I love it. It's like this, it's wolf in the snow. It's like a dancing wolf with snow. It's really pretty. But maybe I'll take a picture of it. I'll show it to you next time. So she comes back every once in a while. She lives, quite remotely. She lives with
Did
this
you do
artist.
a PI as well, or just the cataract?
I think I just did the cataract. Doesn't look like I did a PI. We'll see. Doesn't look like I have up until that point. Looks like sometimes with the DALK, it's a good idea if you're doing a secondary cataract to put air into the AC. In this case, I think it might also help with keeping the angle open, which we did preserve her angle. Does this look like a PI there? It's in the area where the incision is, so it makes sense. I don't know, I don't remember doing one. Let's just see.
It's just a shadow, right?
Pardon? You just muted yourself, Tanya. That's a good trick.
I was saying that the shadow comes and goes, so I don't think there was a PI there.
Okay, yeah, it's possible. We'll just speed it up a little bit more. See.
And if you wanted to, where would you think doing it? I don't think you would do it where your incision is. I'm not sure.
Yeah, I think where it's easiest. There, I did do a PI. Yeah, so I think just because the eye was inflamed and we were in an angle closure situation, but thank goodness she's ended up with fairly decent vision in the eye. But so there's disadvantage of doing it as a staged procedure is that you're the other reason I don't like doing the staged procedure, and I think a priori I always prefer doing combined, is that you're clearing the visual axis. It just bugs me to do half an operation where you put a new cornea on there, but the patient still can't see for a year because they've got lens opacity. So I think we'll quit for there, but I've got lots more of interesting cases that was saved, and that's the nice thing about being in practice for a long time, is you get to see a lot of different stuff